Hello everyone. In this video, we are going to discuss about the meningitis and preventable causes of the mental retardation. Uh, about the meningitis, there are certain questions are asked regarding the meningitis in our university exam. One of the question is that a 2-year-old unimmunized boy admitted with history of low-grade fever for last 3 weeks, and there will be recurrent seizures and altered sensorium for the last 2 days. On examination, next stiffness is elicited. Then what is the most probable diagnosis and what are the differential diagnoses, and write down relevant points in history and clinical examination to arrive at a diagnosis. That is one of the question. Then next is a 5-year-old child admitted with a history of fever of for 2 days with altered sensorium and seizures, several episodes without regaining consciousness for more than 30 minutes. On examination, child had temperature of 102 degree Fahrenheit with neck rigidity. Discuss the clinical condition, diagnosis, investigation, and treatment for the above mentioned scenario. So these are the main essay questions which are asked in the topic related to meningitis. Then short essay questions are discuss the etiopathogenesis, clinical features, laboratory investigations, and management of the pyogenic meningitis. And also describe the pathogenesis, clinical features, and management of tubercular meningitis. Then about the short answers as laboratory diagnosis of pyogenic meningitis, cerebrospinal fluid findings in acute meningitis, long-term complications of pyogenic meningitis. Then about the CSF findings in partially treated pyogenic meningitis, diagnosis of tuberculous meningitis, about the lumbar puncture, and common organism causing meningitis. So these are the usual questions regarding the meningitis, which are usually asked in our university pediatric examinations. So first we have to start with acute pyogenic meningitis. So as an introduction or definition, it is an inflammatory, that is itis, which means inflammation. So it is an inflammation which responds to inflammatory response to bacterial infection involving the brain and spinal cord. So it is an inflammatory response to bacterial infection which involve in the brain and spinal cord, and it is more common in the age group of 1 month to 5 years of age. And about the etiology, what are the etiological factors or what are the organisms which causing the acute pyogenic organism? The common organism which are responsible for is Streptococcus pneumoniae, then Haemophilus influenzae, and Neisseria meningitidis. And the most common organism is Streptococcus pneumoniae. In the questions I read, that is regarding the meningitis. If there is any history of unimmunization or fever, lethargy, poor feeding, seizure, or neck rigidity, that is the meningeal sign. And if there is any altered sensorium or coma, and unrelenting headache or photophobia is there in the question, it should be a hint towards the diagnosis of the meningitis. So it should be kept in mind. The hint like unimmunization, fever, seizure, neck rigidity, then bulging fontanelle, altered sensorium or coma, and unrelenting headache or photophobia. These are the features or hints sensitive towards the diagnosis of the meningitis. So once again, go back to the etiology. The common organisms are Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitidis. And the most common organism is the Streptococcus pneumoniae. And Haemophilus influenza type B incidence has now reduced because of the impact of immunization. In the newborns, the most common organism is the Escherichia coli, group B Streptococcus, and Listeria. Then about the pathology, the bacteria gain entry into the meninges by either by the hematogenous route or by the contagious spread. Beyond newborn period, most bacteria that cause meningitis colonize the nasopharynx first. Accumulation of the exudates in the subarachnoid space over cerebrospinal hemisphere and over cerebral hemisphere and base of the brain. There will be hydrocephalus can develop secondary to the obstruction of CSF pathway. That is all regarding the pathology. That is, a route of transmission is by the hematogenous spread and contagious spread. That is, bacteria gain entry into the meninges by the hematogenous spread to the contagious spread. Then, beyond newborn period, most bacteria that cause meningitis colonize the nasopharynx first. That is, the present as a nasopharynx infection first. Then it colonizes the meninges. Then, after the effects of the meninges, there will be collection of the exudates in the subarachnoid space over the cerebral hemispheres and base of the brain that results in the production of hydrocephalus due to the obstruction of the CSF pathway by this collection of the exudates. That is the pathology behind the acute pyogenic meningitis. Then about the clinical features, it is characterized by sudden onset with high fever, vomiting, irritability, headache, and seizure. And physical examination shows bulging anterior fontanelle, neck stiffness, and positive chronic sign and Broditsky sign. That is the signs of meningeal irritation. So these have to be looked for. Then signs of the raised intracranial tension like papilledema, cranial nerve palsies, hypertonia, and hyperreflexia which may be present. And these signs are often absent in the infants and young children. So these are the clinical features. That is sudden onset high-grade fever, vomiting, irritability, headache, and seizure. Then physical examination show the signs of meningeal irritation, bulging anterior fontanelle, and neck stiffness. And also there will be signs of intracranial, raised intracranial tension is also there. That is about the clinical features. Then about the investigation, we have to go for the routine CBC. In that, we have to find out the findings as leukocytosis, that is neutrophilic leukocytosis. That is because of the infection. Then about we have to go for CSF examination. See, in that CSF examination, the pressure of the CSF is increased and the CSF is disturbed. Total cell count is increased with the polymorphonuclear leukocytes. Then the CSF protein is increased and CSF sugar is decreased, and the CSF sugar to blood sugar ratio is less than 66%, CSF gram stain and culture which may help to isolate the organism. So these are the CSF findings in the case of the acute pyogenic meningitis. These are usually asked as a short note, that is regarding the what are the CSF finding in the case of the acute pyogenic meningitis. These are the CSF findings. That is pressure is increased, CSF is troubled, and total cell count is increased with polymorphonuclear leukocytes. Then CSF protein is increased, CSF sugar is decreased, CSF sugar to blood sugar ratio is less than 66%, CSF gram stain and culture which may help to isolate the organ. So these are all regarding the CSF examination. Then we have to go for the blood culture for the isolation of the organism. And the total count is increased, ESR is increased and CRP positive because of the inflammatory reaction. And we have to go for neuroimaging like CT with the contrast or MRI, which helps to detect the complications like hydrocephalus, then ventriculitis, and in fact, we have to look for the complications also in the case of acute pyogenic meningitis by the help of the neuroimaging, that is CT with contrast or MRI. Then about the treatment, the mainstay is the antibiotic therapy. Before getting the report from the cultural sensitivity, we have to go for initial empirical therapy, usually consists of third generation cephalosporins like ceftriaxone or cefotaxime. So, if the age is less than 3 months, the antibiotic regime is cefatoxime, 50 milligram per kilogram dose 6 hourly, or ampicillin 50 milligram per kilogram dose 6 hourly. And alternate is the ampicillin plus gentamicin. And if the child is 3 months to 1.5 years, we have to give cefotaxime or ceftriaxone, and alternate is the meropenem. And add vancomycin with ceftriaxone in areas where penicillin resistance pneumococci are greater than 5%. For the suspected Pseudomonas infection, we have to give ceftazidime. In neonates and suspected gram-negative organism, we have to give aminoglycosides. And antibiotics are modified according to cultural sensitivity after this empirical therapy. And duration of antibiotics is about 10 to 14 days. And Dexona, that is dexamethasone, before first dose of antibiotic should be given. The clinical tips, if goal is the goal is usually Dexona, that is dexamethasone, that is followed by the empirical antibiotic, followed by the CSF within 30 minutes. If focal neurological deficit is there, empirical antibiotic followed by the CT scan, brain followed by the lumbar puncture. So that is the order of the treatment and investigation. Supported treatment, we have to give a short course of steroids, that is dexamethasone 0.15 milligram per kilogram every 6 hourly is recommended, particularly in the Haemophilus influenza meningitis. And anticonvulsants also give to control any seizure attacks. And mannitol or 3% normal saline to treat the raised intracranial tension. So most of the supportive treatment is to help in the relief of the symptoms. So anticonvulsant to control seizures, to for raised intracranial tension, we have to give the mannitol of 3% normal saline. So that is about the supportive treatment. About the chemoprophylaxis, Haemophilus influenza type B, all home contacts rifampicin 20 milligram per kilogram per day for 4 days should be given. And unvaccinated infants, we have to give vaccine 3 doses. If the child is greater than 12 months, we have to give 1 dose. In the meningococcal meningitis, rifampicin 10 milligram per kilogram every 12 hours for 2 days, or ceftriaxone intramuscularly single dose 125 milligram to children. These are the chemoprophylaxis for the acute pyogenic meningitis. Then about the complications of the meningitis, that is acute pyogenic meningitis, complications develops. These are One of them is ventriculitis and brain abscess, subdural effusion or empyema, then hydrocephalus. So long-term sequelae are the mental retardation, cerebral palsy, epilepsy, deafness, and speech problems. So these are all regarding the acute pyogenic meningitis. Then also the short note or is regarding the lumbar puncture and CSF examination, and CSF examination is CNS infection. So about the normal CSF, the volume is 125 cc, production per day is 500 cc, half-life is 3 hours, and the color is colorless, appearance is clear, and the microscopy, the WBC count is normal count is about 0 to 30 per millimeter cube, and RBC count is 0 to 5 millimeter cube, protein is 20 to 40 milligram per deciliter, glucose is 40 milligram per deciliter, and the chloride value is 130 to 140 millimole per liter, and intracranial pressure is about 150 to 180 millimeters of mercury. So that is about the normal CSF value. Then about the lumbar puncture procedure, there are steps. That is, we have to take a consent from the patient or relative, then position, lie on the side, lie on the one side, back facing the examiner, then curl into a ball. That is, all the body of the patient is curled into a ball. The site is at or below the level of L3, L4 interspace, line drawn between the posterior iliac crest. Skin preparation, we have to clean with the betadine and spirit. Local anesthetic, we have to give the 1% lignocaine subcutaneously, injection locally. We use 20 to 22 gauge needle. Space, insert a lumbar puncture needle in the direction of the umbilicus till you enter the subarachnoid space as indicated by the giving the way sensation to free flow and CSF. Volume, the maximum 50 ml is enough for the most of the tests for in the case of lumbar puncture. Indications for the lumbar puncture is that both diagnostic indications are there and therapeutic indications are there. For the diagnostic indication, in the meningitis like pyogenic, tubercular, and viral meningitis, we have to go for lumbar puncture. Then encephalitis, subarachnoid hemorrhage, tumor cells, demyelinating disorders like oligoclonal blans in IgG, SPSP, and multiple sclerosis. And recently, it is also used for CSF, PCR for cytomegalovirus, enterovirus, varicella zoster, Epstein-Barr virus, herpes simplex virus, PCR. And the therapeutic are to remove the CSF in raised ICT in the hydrocephalus, intrathecal drug administration like antibiotics and chemotherapy drugs administration intrathecally, and injection of contrast media for the myelography, and also used to give the spinal anesthesia. So these are the therapeutic indication for the and also this is the diagnostic indication for the lumbar puncture procedure. So this is the procedure. That is the patient is lied on the one side and the back is faced to the examiner, and it is the child or the patient is curled like a ball. This is the space between the L3 and L4. Then about the complications of the lumbar puncture, headache in the older children, introduction of infection through this route like meningitis in the case, in this complication, and cerebral herniation is total indication. Then contraindication for the lumbar puncture is that raised ICT due to suspected mass lesions in the brain. Papilledema on fundus is a contraindication. Critically ill child with the shock and cardiorespiratory instability is a contraindication. Signs of impending cerebral herniation in a child with probable meningitis is a contraindication. Then local skin infection, thrombocytopenia less than 20,000 per millimeter cube. Then if first CSF is traumatic, and lumbar puncture can be repeated after 48 to 72 hours. In newborn, after completion of treatment for the pyogenic meningitis is a controversial, and poor clinical response therapy in 48 to 72 hours. So these are the usually these are the contraindications for the lumbar puncture, that is raised ICD due to the suspected mass lesion in the brain, papilledema, critical ill child with the shock and cardiorespiratory instability, the signs of impending cerebral herniation, a local skin infection, thrombocytopenia less than 20,000 per millimeter cube. So these are the contraindications for the lumbar puncture procedure. Then about this is most commonly as the short note, that is CSF findings in specific disorders. So About the so there are different meningitis are there, that is pyogenic meningitis, tubercular meningitis, and viral meningoencephalitis. In these there will be different series of findings are there. So the pressure is usually elevated in the case of pyogenic meningitis and tubercular meningitis, that is about 100 to 300 millimeters of mercury, and in the viral meningoencephalitis there will be normal or slightly elevated. And the cells, there will be predominance of the polymorphonuclear leukocytes, but in the tuberculous meningitis, there will be predominance of lymphocytes. But in the viral meningoencephalitis, there will be predominance of the mononuclear cells. Protein is 100 to 500 milligram per deciliter, and tuberculous meningitis, the protein is increased 100 to 300 milligram per deciliter, and that is high protein content in the case of tuberculous meningitis, and 50 to 200 milligram per deciliter in the case of viral meningitis. Then glucose is decreased in the case of pyogenic meningitis, but is usually less than 50 milligram per deciliter in the case of tuberculous meningitis. Generally, the glucose value is normal in the case of viral meningoencephalitis. Then the organism can be seen on the gram stain. The acid-fast bacilli can be recovered on the culture or CSF PCR. So that is all regarding the CSF findings in specific disorders. Then about the preventable causes for the mental retardation. Um, During the antenatal visit itself, by the antenatal USG examination of the markers, we have to prevent the occurrence of mental retardation of the child by adequate examination during the antenatal. That is chromosomal disorders like Down syndrome, Turner syndrome, and Fragile X syndrome. Maternal infections like rubella, cytomegalovirus infection, toxoplasmosis. Metabolic disease like PKU, galactosemia, and mucopolysaccharidosis. And CNS malformations, example hydrocephalus, and the neuronal immigration defects like lysencephaly and schizencephaly. That is, they are the so these are can be prevented by the adequate antenatal examinations and the imaging studies. Then the perinatal causes like a birth asphyxia, birth trauma, prematurity, intracranial hemorrhage, we can be prevented by administering certain measures. Then postnatal causes like infections like meningitis, encephalitis, hypoglycemia and hypocalcemia, malnutrition, child abuse and neglect, chronic stress, hypothyroidism, that is considered hypothyroidism, and heart injury. These are all should be prevented. So these are the preventable causes for the mental retardation. So that is all regarding today's topic, this in this video's topic. Thank you.